Good morning. I'm Dr. Michael Miller. I'm going to take you off on a tangent. In my world, the function of the heart is to keep the feet and legs alive, as opposed to keeping the patient alive. I'm one of the only full-time wound docs, and I run Miller Care Group, which is the largest non-hospital affiliated multi-specialty group in Indianapolis and Indiana, I believe. I'm going to apologize because when I'm done, I have to get down to my clinic. For those of you that want more information, my marketing liaison, Ashley, is in the back. Stand up real quick. So if you have other questions about what we do as part of the healthcare system, we're happy to provide it. But I want to talk about amputation prevention. We've created a new paradigm, and we believe that it's going to radically shift amputation decision-making from clinical-based to patient-based, which again is a fairly new paradigm. So, of course, here is an unfortunate gentleman that we saw in his home. He had bilateral lower extremity amputations. The interesting thing is that it doesn't stop him at all from being functional.
Go ahead.
What are you going to do?
I'm leaving him. I'm dying.
Which is how he got the sore on the bottom of his stump. But his preference is to not wear his prosthesis if he doesn't have to, and so that's how he ambulates in his apartment. Medical decision-making is mostly clinically based. For those of you that have had any kind of surgery, kids with tonsils, what have you, you go to the doctor and basically you have to meet certain clinical criteria. It's not a matter of what's going on with you, it's a matter of whether or not the boxes are checked. And again, cholecystectomy, gallbladder surgery, has definitive criteria before they can take it out. Cesarean sections, definitive clinical criteria, hysterectomies, and of course to get someone into the hospital is an absolute nightmare, because there are very specific criteria. And everything that occurs in medical care now involves, criteria, except lower extremity amputation, interestingly. There are no criteria to decide whether or not a lower extremity amputation should occur. And it's an international crisis. We all see patients that have lost one or more legs, and the problem is that the decision-making process had nothing to do with the patient at all. And in fact, the recent studies show that despite all the technology, amputation rates are increasing in the United States and worldwide. So the question is, if we're reading about all these fabulous technologies, devices, and whatever, with all the improvements in healthcare, why is the rate of amputation still increasing? The problem is that the decision to amputate a lower extremity is in the hands of those who have the least to lose, namely the clinicians, because the patient is the one that's going to suffer the consequences, not the clinician. And of course, it's a self-fulfilling prophecy. As one of the only full-time wound care docs in the state with 24 years full-time experience, what we hear from our patients is I was told that because they could not get it to heal, the only option they had was to amputate. So the question real briefly is, what are the issues regarding why and when a lower extremity amputation is performed, and what kind of factors need to be looked at? The problem is that surgeons are trained to cut off things. I'm a board-certified general surgeon. That was my training. And the question is, how many of them are trained in limb preservation? How many of them are trained to heal as opposed to cut off? And how many of those working day to day have the chance to attempt limb salvage? That's the term we use. Or whether they say, look, this is not going to get better. I've got other things to do. Let's just take off this leg and call it a day. And the problem is, if the decision is poorly considered, which unfortunately it is in the vast majority of cases, who suffers the consequences? So again, are all those who amputate, who perform this potentially horrific procedure, are they all trained the same? Do they all have the same skill level both to prevent and to perform? Is the decision to amputate based on the ability of the surgeon, or anything to do with the patient? And the question we asked ourselves was, does the patient play a role in anything regarding the amputation other than the presenting condition? So until this month, actually until about 10 days ago, there was no criteria, no guidance for anyone to consider whether or not a patient should have an amputation. And the decisions that we looked at were based only on clinical criteria and the ultimate presumed diagnosis. In other words, if I don't cut this off, it's going to spread. And patients had a vision of Pac-Man chomping up their leg and heading toward their head. So again, the decision to recommend and perform involved every aspect of the patient except the patient. So if you could completely take all the clinical features out, where would you go? And where does the patient fit in? Of course, what do you look at in any kind of medical scenario? Age, weight, height, religion, sex, economic status, sexual orientation, hair color, medical history, types of insurance. All these things are considered and potentially considered, but the question is, what's the pertinence? And of course, the obvious question is, surely somebody has looked at all these patient factors when they're considering not just amputation, but any surgical procedure, or have they? We looked at 70 years and 200 articles of medical literature, and we looked at things that use the term amputation or criteria or indications. And it's not possible to look at everything, but we did the best we could. And the question was, should the specific surgeon's skill level have anything to do with the decision to amputate, because it's radically different between surgeon and surgeon? And the question we asked is, if you could identify universal patient considerations for amputation, what might those be? Pain, certainly a lower extremity with pain, that's a consideration. You've got to do something if you can't ameliorate the pain. And our goal was to look at patient-centered issues, and pain was low-hanging fruit. That was an easy one to look at. But we said, what else pertains to patients? And the goal was looking at patient-centered issues. So pain was good, and we looked at others. And the other one was functionality, because merely because you've got a black toe, an ulcer on your foot, does not itself mandate amputation, and yet in the minds of most surgeons, unfortunately, it does. So we looked at what we've called the keyhole criteria. We said, what are the most basic things under which someone should consider performing an amputation or having an amputation done? And we called them keyhole, as if we're looking through a doorway at a larger area. And basically, intractable pain was the first one we came up with. But the second criteria we came up with, besides pain that can't be controlled, was the concept of functionality. So basically what we came up with, at least initially, was to say, you know, if a patient has pain in that extremity that can't be ameliorated, that would be a reasonable consideration to consider amputation. And the second keyhole criteria was patients that have acceptable surgical and mental, and the extremity must be functionless. So we looked at all these criteria. And what we came up with, which was published last week, was the first patient-centered criteria internationally to give surgeons and others guidance in amputation. It's called a comprehensive scoring system to evaluate risk factors regarding lower extremity amputation. We call it the Miller-Nugent Amputation Scale Score, and the acronym we came up with was MENACE. Basically, the MENACE scale is based on patient criteria, economic status, mental behavioral status, available support, environmental factors, and rehab status, 0 to 2 points. And our recommendation was that you should have at least 7 points after meeting one of the two keyhole criteria, pain and an extremity that meets criteria and is functionless. So if they use that extremity to move chair to potty, potty to bed, to stand for a moment, it's not functionless, and you don't meet criteria. So again, this criteria has been used by my group and myself for many, many years. We've had extraordinary success in stopping amputations and not doing amputations that the other hospitals, physicians felt was absolutely necessary. And so basically our concept was that criteria in medical care, amputations, lower extremity disease, and we believe that MENACE extends to any surgery or any medical intervention performed, should be based on patient-centered criteria. With that, I thank you very much.